Hi, this is Zachary Crawford to discuss type 1 diabetes mellitus. The clinical features of type 1 diabetes are going to be similar to type 2 diabetes, although with some important caveats. You're still going to have polyuria and polydipsia, so increased urination and increased thirst, fatigue, weight loss, and blurred vision. Type 1 diabetics can also have diabetic ketoacidosis. This is often a diagnosing event in type 1 diabetes, and this is because there is a lack of insulin being produced in which the body is not able to utilize the circulating glucose, which then further drives hyperglycemia and then can also cause ketone production. Type 1 diabetes is also commonly a childhood onset disease, and this is because of the autoimmune destruction of the pancreatic beta cells. And this will ultimately require a lifetime therapy with insulin, and type 1 diabetes is typically not related to obesity. Diagnosis is similar, so 2 fasting glucose measurements greater than 125, a single blood glucose level of 200 plus symptoms, so the polyuria, polydipsia, and a variety of other symptoms. Increased blood glucose greater than 200 after a 75 gram glucose load, or a hemoglobin A1C greater than 6.5% can then be repeated in 2 to 3 months. Ultimately, patients who are diagnosed with type 1 diabetes, because this is a rapid onset of disease, generally going to have the 2 fasting glucose measurements greater than 125 or the glucose level of 200 plus symptoms. So because they will require insulin to live, we'll go over the mechanism of action of insulin. So in the liver, it increases glucose storage with upregulation of GLUT2 transporters. In adipose tissue, it encourages triglyceride and glucose storage via GLUT4 transporters. And then in skeletal muscle, it is glycogen and protein synthesis as well as storage through GLUT4 transporters as well. Insulin is indicated for type 1 diabetics, and then type 2 diabetics without hemoglobin A1C control on oral anti-hyperglycemics or starting off with a very high hemoglobin A1C. There are a variety of insulin preparations. So rapid acting include insulin, lispro, aspart, and glulisine. These have a very quick onset of 5 to 15 minutes and peak in about 30 to 90 minutes with a duration of about 4 hours. So overall, in terms of insulin regimens, the rapid acting are going to be your mealtime or your correction dosing just because of how quick they work and the duration of about 4 hours or so. Short acting, which includes insulin regular, has an onset of about 30 to 60 minutes, peaks in about 2 to 3 hours, and will last for about 6 to 8 hours. Intermediate acting, which is NPH insulin, has an onset of 1 to 2 hours, peaks in about 4 to 6, and has a duration of about 10 to 16 hours. So as we review insulin regimens, NPH insulin is a common use as well. And then lastly is long-acting insulin. So this is insulin glargine, detamir, gludac, and then also Basaglar as well now. It has an onset of about 2 to 4 hours and a duration of about 20 to 24 hours. The long-acting insulin can be used for type 2 diabetics. This is initially what they're started on if they don't have very great hemoglobin A1C control with oral anti-hyperglycemics. And for type 1 diabetics, this provides the kind of baseline insulin release that your body normally has throughout the day, and they can take the rapid-acting insulin for mealtime coverage. There are generally 2 different types of insulin regimens, conventional versus an intensive. In conventional, you're going to end up providing both the basal and meal-related boluses together. The goal is going to be less than 8% for the hemoglobin A1C, and this is to reduce the side effects associated with diabetes. It's much easier for patients to manage. You do have a reduced risk of hypoglycemia because you are allowing them to have some higher blood glucose levels since the goal is less than 8%. However, you do have increased risk of microvascular complications. Oppositely, intensive therapy, you do separate your basal and mealtime insulin. So you'd use long-acting insulin at night or twice daily in the morning and the evening in a situation with insulin detamir, and then you would provide specific mealtime insulin as well. You're going to have a much more frequent blood sugar testing, generally before each meal and before bed. Your goal A1C is less than 7% with a fasting range of 80 to 130. It is more complicated, but it does allow for greater flexibility in lifestyle. With the conventional regimens, patients need to eat about very similar meals throughout the day, just because you don't have a whole lot of change and you can't titrate the insulin very much. Whereas with intensive, patients will specifically give themselves the amount of insulin required to have that meal plus cover any correction as well. And because of the improved hemoglobin A1C and fasting blood sugar levels, they do generally have a reduced risk of microvascular complications. So 2 different regimens. The conventional, generally twice daily with either regular and or NPH. There are a couple combination insulins available. You're only going to measure your glucose 2 to 3 times a day to titrate that fasting glucose of 80 to 160. Oppositely intensive, like I said, will be a nighttime basal injection. You have mealtime coverage with bolus or rapid-acting insulin that you would then need to do carbohydrate counting and correction for, and then you're going to measure your glucose 4 to 5 times a day. So starting off with insulin dosing, you're going to calculate your total daily dose of insulin. You're going to take your weight times 0.55 units per kilo. You're going to split that approximately in half. So 40 to 50% of that will be used for the basal insulin dose, and the other 50 to 60% will be used for mealtime coverage. You can then calculate a carbohydrate coverage ratio that's used 500 divided by the total daily dose of insulin, and that'll give you the grams of carbohydrate covered by 1 unit of insulin. This is important for the more intensive therapy. So if a patient's going to eat, they have to add up the amount of carbohydrates they're going to eat in their meal, and they then give themselves insulin based off of that. Then they also calculate a correction factor. So you take 1800 divided by the total daily dose, and that'll tell you how much glucose will be lowered by 1 unit of insulin. So moving into a very basic example here, average weight male, 70 kilos times 0.55 units per kilo gives you about 38.5 units of insulin per day as a total daily dose. So you then split that up into 40 to 50% for nighttime. So 38, 39, 40 units. Maybe you say take 17 to 20 units at night, and then the rest will then be divided up throughout the day. So for the carbohydrate ratio, you would take 500 divided by the total daily dose, which is 38.5, and that gives you about 13 grams of carbohydrates. That means that 1 unit of insulin is going to cover every 13 grams of carbohydrates in their meal. So if they add up and they have 26 carbohydrates in their meal, they're going to take 2 units of insulin. If they have 39 carbohydrates, they're going to take 3 units, and then they kind of can factor base calculations off of those. You're also going to have a correction factor. So 1800 divided by the total daily dose, which is 38.5, gives you 46.75. So that says 1 unit of insulin will lower their glucose approximately 45 to 50 milligrams of glucose per deciliter. So when they go to check their blood sugar prior to a meal, they're going to have, let's say they have 26 grams of carbohydrates in their meal, and their blood glucose is 200. So we know their goal is less than 130. So this patient would say they take 2 units of insulin for that 26 carbs, plus 1 unit of insulin for the correction factor to get their blood glucose down from 200 to about 150. So they would take 3 units of insulin for that meal. As patients are kind of progressing and they are keeping track of their numbers, you can slowly start adjusting these. So maybe someone requires more insulin. Maybe their correction factor ends up changing to 1 unit of insulin will only cover 10 grams of carbohydrates, or maybe they're sensitive and actually covers 15 units. And this is where you can monitor and fine-tune your very intensive insulin regimens as well. So ultimately then, for calculating their insulin management with their long-acting, so you'd want to increase or decrease the basal insulin by 5 to 10% based on the morning fasting levels. So their goal is going to be 80 to 120 when they check their blood sugar in the morning before they eat breakfast. If they are high in the 150s or 200s, then you would increase the insulin by 5 to 10%. If they're on the lower end of 80s into the 70s, then you can kind of decrease their insulin as well. Adolescence and puberty may increase insulin requirements just because everything going on hormonally within the body, and they may end up needing up to 1.2, if not 1.6 units per kilo per day. But this is something that you would just determine with the endocrinologist or pharmacist assisting in managing their diabetes and the glucose that they are recording from their testing. Additionally, they will require some sort of insulin sick day management. Just like in a patient who is sick, their body secretes more steroids. The increase in steroid release or the overall response of their body towards any sort of illness generally requires an increase in the amount of insulin that is required. So you may have to change both the basal and the bolus based on the blood sugar and carbohydrate intake. You do want to continue the frequent blood sugar checks to make sure everything is in line. These patients can very quickly go into diabetic ketoacidosis. So if they have an upper respiratory infection, even just a viral common cold, if they are not increasing the amount of insulin as necessary for sick day management, they can potentially go into diabetic ketoacidosis. So generally, patients will monitor their urine ketones at home with urine ketone sticks. So if they have a small amount of ketones in their urine, they're going to increase their correction by 5%. If they have medium or large, they're then going to increase their insulin correction by 10, if not 20%, can potentially go even higher. But it's important to have an insulin sick day management protocol in place between the endocrinologist and the patient, and in close communication with the prescriber or with the pharmacist to make sure that everything is managed appropriately. And this concludes type 1 diabetes.